I would now invite Dr. Sachithanandam to give his talk on orthopedic uses of HBOT, his own experience.
Good afternoon. At the outset, I would like to thank Dr. Ravi for inviting me for this interesting talk on hyperbaric oxygen therapy, which is going to be one of the futures of medicine as a overall, and it will benefit a lot of patients. My role is to talk on the hyperbaric oxygen therapy in orthopedics, and to say that I've almost used in all the conditions which Dr. Sexton has used since last 7 years, but the numbers are very few. I'll highlight a few points on that. So let me first stick on to orthopedics. So we'll dwell in the role of oxygen in our bodies, condition where HBOT is beneficial and how it works at the cellular level. A majority of it, Dr. Sexton has already told the physiology of how hyperbaric oxygen works. So this is where the magic happens in this chamber. This is an old, the chamber is old, which was imported. Now a lot of advancements have come in the chamber. And I was the first one to have it after Madras in the whole of Tamil Nadu. Our experience and success stories. So the role in orthopedics where I've used is in open fractures, crush injuries, cellulitis, AVN, arthritis, and deep-seated infections, which I'll just highlight a few conditions after I finish the orthopedics. So this is the basic mechanism of how hyperbaric works. Dr. Sexton has explained. So inflammatory, it decreases the inflammation by the cytokine kinase inhibitors at the molecular level of the inflammatory process. It enhances the angiogenesis enhancement by increasing the vascular growth factor and other factors, which increases the new blood vessel formation, which is the key for the wound healing. The most important of all, which I think Dr. Sexton has not mentioned, is the stem cells mobilization. There are a lot of studies which have proved that after hyperbaric oxygen therapy, the stem cells count in the blood has increased thousands and thousands of whole CD3MA cells, they call it, which has increased. The reason why I'm highlighting this is when the tissue heals after your hyperbaric, normally what we study in pathology is a wound heals by cicatrization, that is by fibroblast, and then a fibrous tissue always contracts. That's the basic nature of histology and pathology. But when a wound heals by mobilization of the stem cells, which I will show you in subsequent slides, you have a normal tissue there. You don't have a cicatrized tissue or a fibrous tissue there when the wound heals. So that is the most important, which you have stem cells are mobilized in thousands and thousands of numbers. Then you have suppression of cellular sequences and elevation of antioxidant activity. So these are the basic mechanisms by which hyperbaric oxygen. And the most important is decreases edema by vasoconstriction. And the two most important mechanism of action of HBOT in my experience is it is the most powerful anti-inflammatory drug in the world as of today. It will easily beat a steroid. If you are giving a methylprednisolone for any condition, you don't need to give a methylprednisolone. I'll show you some examples of that. So to sum it in one word, it is the most important anti-inflammatory drug. So wherever you have inflammation in the body, however deep it is, this drug will act. So that's how oxygen will act. But the key is the pressure of oxygen. The key is the giving it that high pressure. So these are the basic mechanism of action and how it works. So coming to open fractures, I've used it in mostly lower limb fractures in upper tibia and lower tibia, lower 1/3. So as orthopedicians, we know that upper tibia Bicondylar fractures, you need to wait for 7 days to 10 days before the edema subsides and then do the surgery. And then you still have the risk of infection and the compartment syndrome. So, and then the lower one-third is the most common, where you have less soft tissue. So the risk of any open injuries, the risk of infection is very high. So my protocol has been any open injuries like this, I do a wound debridement. I immediately suture the skin to whatever skin available. But when I suture the skin, I make sure I cover the bone first. I leave the soft tissue open if I don't have enough skin. So when I cover the bone and when I start giving the hyperbaric oxygen therapy, so that's Mr. Prasad, 23-year-old, after 15th day of HBOT. In a normal course, when we deal with open fractures, when the tissue here, the tissue in the photo in the middle, when we suture the tissue, when you have an injury, the margins of the skin are always necrosed. When they get necrosed, the bone gets exposed, and then the whole problem, we need to move on. So the protocol in orthopedics is you have a grade 3 injury, you go for an external fixator, heal the wound, and then go for a definitive fixation, which I think sir agrees with that. That's what we do. Now with this oxygen therapy, all the processes are mitigated. You straight away put a nail, you cover the skin, you put them in oxygen therapy, the wound heals, the fracture becomes a closed fracture, and then you proceed on with a normal fracture healing pattern. So this is one example. This is Mr. Subramaniam. If you notice that this Subramaniam had not filariasis, he had a gross severe left lower limb edema because of an inguinal surgery due to lymph node resection. This was his pre-op photograph on the left. That's immediate. So in this case, I was a little lucky to get the skin opposed to each other. But even when you get the skin opposed, those days when without oxygen, the tissues used to necrose, the edema used to be there, and that's the last thing on 20th day of HBOT. So this, we give it aggressively, like twice a day for 10 days. So the initial 5 days is what is crucial for the vascularization to take place. So after the 20th day, the fracture is healed normal, and he had a muscle injury. He had a grade zone 5 muscle injury with a little foot drop. All of them are sutured, and then a 20th day, you converted the closed fracture. We have mitigated the external fixator. We have mitigated any plastic surgery flaps, all that. This again is the lower, it's a shattered tibial fracture in the lower one-third. Again, we had an open wound. We put on the fixator, the upper tibial. So we had to go with the ILIZAROV method for the fracture fixator. So one shot, you just have to put ILIZAROV. End of it, all these open wounds, we never had to do any plastic surgery. You put it 20th day. Usually a fracture, all these open type of fractures, about 20 sessions is good enough for them to heal well. You don't need anything more than that. So this all went on to heal well. And not only that, the bone healing also is back to normal because oxygenation, your tissue healing, bone healing, everything heals well normally. This is an ankle injury, open subtalar subluxation. As you all know, in the heel, posterior aspect of the heel, the wound healing is always delayed. So that's once after suturing, you put a plaster and then you give oxygen therapy. Any wound around the tendo Achilles or the heel, till today I have not had any delayed wound healing. So this is another person with an open fracture. This is upper tibial fracture with open thing. So I straight away plated it only with the confidence. Normally upper tibial fractures, we don't plate it if you have an open wound. But I took a little risk, no doubt about it. Put the plates, did a definitive fixation day 1, and then put them on hyperbaric oxygen therapy. And eventually, sometimes it will have small wounds, but at the end, you cover the big wound, make the big wound into a small wound, and then you teach them home dressing, and then they do well with that. Now this, again, is which I've done recently. This was an open fracture. 2 wounds were like that, side by side, exactly over the anteromedial surface of the tibia, exactly where the bone is exposed. And it was a large butterfly fragment. So I had to extend that incision so that I reduce the butterfly fragment, put in a nail, then I had to compromise which wound I had to close. So what I did was I closed the wound over the bone. Then I left that open wound, that also the bone was exposed. So I took a little of the periosteum, a little of the soft tissue, fat soft tissue, and sutured with catgut and covered that bone. And then I gave him 20th day of HBOT. On the 20th day, if you look, the wound is getting healthy. The skin where I sutured is not necrosed. Usually it necroses. That's what our experience say. And then when he came, with that small wound, I taught him home dressings. The nail is inside, the fracture is stable. There are two things you need for a fracture is stability of the fracture. So eventually, when I was saying about stem cells, if you look at the leg on the last picture on the review, you don't see any fibrous tissue, you don't see any scar. If you look very closely, you don't see any scar. The skin looks absolutely normal. Now, this is where the role of stem cell mobilization comes into play, because I was in fact astonished how come it's healing normally. Then when we went back to the literature, we had seen that the stem cells is the reason for the wound healing to create a normal tissue there for it to have happen. So if you look at that boy, now it's just 2 months now, I put him on a PTB and he's back to of course, we have to wait for any non-union or not, and time will tell. But at least we have converted the open fractures into closed fractures. I'm sure a normal protocol, orthopedics, we need to have an external fixator or a ring fixator and things like that. But the surgery of 2 more surgeries, the expenses have come down, and the morbidity of the patient has also come down on that. This is another open fracture of the forearm where there's a lot of bone loss, everything. If you see the immediate post-op, so much of swelling, I immediately sutured the wound. That's on the 10th day when he discharged. That amount of edema has to subside in an orthopedics. It will take about a month or 2 months for that edema to subside. Only with the oxygen therapy, the edema completely subsides, the wound healed normally. So the basic I use this again for all my upper tibial fractures. After the surgery, I put them on 5 to 7 sessions, 10 sessions. The healing goes on, especially the upper tibial, we know that there's a lot of edema on the fractures on the leg, and then the risk of compartment syndrome. All that is mitigated. But after upper tibial fixation, you just need about 5 to 10 sessions. So this is another open fracture, forearm. After that, and then that's how his limb looked after my fixation. So these are the open fractures. This is upper tibial fractures with an open fractures. Day 1 I plated, and then 10th post-op day. If you look at the leg on the 10th post-op day, it looks like a closed fracture. All the edema has subsided. The key is anti-inflammatory. The inflammation comes down. The moment the inflammation comes down, the tissue healing happens again. It's much better when the inflammation comes down. And then the risk of infection is very less. This is another case by which it is open. There was a little necrosis, but the area of necrosis, I don't have the final picture with me, but eventually it went on to heal normally, put a PTB, patient is walking normally. So when I sutured the skin, there was a little necrosis of the skin, but the area of necrosis was less. We taught them home dressing. After the home dressing, the wound healed well, and then we put them on a PTB, and then the wound went on to heal well. These are another examples for the same principles, upper tibial fractures. So these mostly the lower tibia is where you have all these open fractures, and you need a lot of procedures for that. Coming to crush injury, this is a crush injury on the foot. We had to combine a plastic surgery flap. We did a free flap on that side, and then if you look at it on the third picture on the 20th day, the flap survived very well. If you look at it, beyond that, there's a granulation tissue on the sole of the foot. That's on the lateral border of the foot. We couldn't cover the flap. Eventually, after HBOT, if you look at that sole, you don't see any scar tissue there. You look at the sole, it's normal plantar skin, God-given plantar skin there, if you look very closely. this again is where the role of the stem cell mobilization takes place. So eventually, this patient, we didn't have to do any other secondary procedures for that raw area on the lateral border of the foot. Normally, we do a skin, before this, we used to do a skin graft or a flap, but that is not a normal tissue. It is not a God-given tissue. Here you have a normal skin, normal sensation of that on the foot on that side. This was my early cases of one of my early cases of HBOT. Yeah, now this is a degloving injury. After this, the area of, there is still some necrosis, but the area has become small, which eventually went on to heal. Especially in the hand, all these crush injuries in the hand where bone was totally exposed, we suture the wound, give him HBOT, and then finally the tissue heals well. Especially the crush injuries in the hand and in the foot, the circulation is maintained in the second day, third day, and then they eventually go on to heal. So this is again on the foot. These are the head injuries when we get a few head injuries. Now, any head injury, this is an example where it's powerful anti-edema. So you see the edema and the swelling on the face. This is on the 10th day, the same patient. On the 10th day, he's back to normal, opening his eyes, and all the edema is gone. Again, the scarring and the edema. Another thing with facial injuries, most of them have a minor head injuries, that's concussion. Normally, the CT brain will be normal, but they'll have a little loss of memory, they'll have a little giddiness. All that with 5 sessions of following head injury, 5 sessions of HBOT, they do well. So this is the lady first day and the third day. The gross swelling there. This is on the third day. So all these facial injuries, just 3 to 5 days, the edema comes down. Your need for IV antibiotics, everything is decreased. You just give oxygen or 1 or 2 days of IV antibiotics, and then they're back to normal, and then they go home. And these can be treated as an outpatient also. You don't need to be admitting them for that. The next most important thing is cellulitis. Cellulitis, it's a real boon for the patient for cellulitis. If you look at that, see the redness and the edema. Normally in a cellulitis, it's in an ascending fashion. Normally it starts with erysipelas infection. You have an erythematous patches there, beginning of a necrotizing fasciitis. If you look closely, the first thing HBOT does is prevents the spread of infection proximally. Within 2 days, any severe infection on the leg, the infection doesn't, of course, we give meropenem, we give piperacillin, tazobactam. There's no substitute for a regular treatment on this. It's only an adjuvant. So the first thing is the patient gains confidence in your treatment. In the sense that normally what we see is, we see in cellulitis, first day you see, second day the skin starts necrosing, then the patient gets worried, then they are worried whether we can go, the septicemia starts developing. So the first thing happens is the edema, infection doesn't spread superiorly, and the wrinkle starts appearing a little bit. The patient gains confidence in you, so the edema slowly starts coming down. By the 10th day, they do well, depending on the severity. So you attack the cellulitis early, 5 to 7 sessions is more than enough. So this again, all these cellulitis, this is on the 10th day. If you look at the last leg, the same thing, if you just leave it with just IV antibiotics, the infection spreads, then the skin, most important, I'm sure sir will, plus senior sir Ramchandran sir will agree that most of these infections will go on for skin necrosis. That is, the superficial skin gets necrosed in cellulitis or in necrotizing fasciitis, which doesn't happen. The amount of necrosis on the skin does not, maybe it reduces to very minimum, or most of the time you can get away with just a medical treatment and oxygen therapy. So this is another case of cellulitis. On the 10th day, see the edema on the left side, erythema, everything is subsided on the 10th day. Now this is the whole limb was completely, it came a little late to me. Eventually what happened is we gave him HBOT for 40 days. We hadn't put a knife till the end. Eventually, we taught him home dressing and then finally went on to heal. After that, he was lost for follow, but it went on to heal after doing regular dressings. So the cases like this, they go on for septicemia, the infection ascends higher, they need to do radical debridements. Nothing has happened. The first thing is patient gets confidence in us. Okay, it is improving. So the patient doesn't run away, especially small centers like us. The patient doesn't run away to a bigger center. They gain confidence and then move on. Now this is another patient with cellulitis. You can see that edema subsides. By 10th day, all 10th to 15th day, everything reverts back to normal. Normally for this, the protocol is about 3 days IV antibiotic, meropenem or piperacillin tazobactam, and then we switch on to oral antibiotics and then ask them to come on a OP basis. This is again cellulitis. So this is a very major indication for hyperbaric oxygen, where you can treat it early, decrease the morbidity of the patient, reduce the surgical risk. The next coming, the newer thing in orthopedics is avascular necrosis. So I have had 2 patients. I had follow-up for 2 years. All these the avascular necrosis, how it works is, the basic pathology in avascular necrosis is you have loss of blood supply. So any loss of blood supply to the bone, the first reaction is an inflammation. As you all know, pathology, inflammation is defined as a tissue response to an injury. So a tissue injury is lack of blood supply. So the tissue response is inflammation in the femoral head. So once there is inflammation, there is always an edema. This edema further compromises on the sinusoidal blood vessels and further compromises. This is a basic pathology of avascular necrosis. So what does this HBOT do in the first? HBOT works only in stage 1 and stage 2, not in advanced cases. So Steenberg stage 1 and stage 2. So this is a patient, Mr. Suresh, bilateral avascular necrosis stage 1, no evidence of subchondral fracture, no evidence of degenerative changes. So this is after a month. It's still in stage 1. There is no evidence of progression of the disease. The patient was totally pain-free by 20th day. This, we had not given any drugs, just oxygen therapy. So how it works is, the anti-edema effect of anti-inflammatory effect of hyperbaric decreases the marrow edema. Thereby, once the inflammation in the bone and anti-edema, the inflammation and the edema in the femoral head decreases and the pain comes down first. Then it helps, the stem cells comes into play and helps to reform osteoblast activity occurs. Whatever is necrosed in the 2-year study has not increased, but that's still not resolved yet. So that is a question. So the same patient, we have followed him up for a year or so. Even after a year, there's no further progression, no further subchondral fracture. Normally in an AVN, by about 1 or 2 years, you'll see the subchondral fractures. It'll go on, the disease progresses to stage 2 to stage 3, and then it goes on to stage 4, and then they eventually land up in an total hip replacement. So if you look at even after 1 year, there's absolutely no progression of the disease. That is, whatever is necrosed, it is not further increased. The remaining bone is still normal. So this is the same patient. This is the MRI. I've done MRI after every 6 months, 1 year, 2 years. This is another patient, second patient. I had follow-up for 2 years. So this is follow-up by MRI reports. So even after 2 years, he has not had any, compared to that, there is no progression in the previous involvement. No evidence of femoral collapse, no evidence of degenerative changes. So this is the main thing which will slowly catch up, because I am alone shouting from the rooftop. It's still not reached the orthopedic population. So, but I've seen the patients by 20th day. I measured it on Harris hip score and Oxford hip score. If you look at it, by 10 months, by even 30 sessions, this I have had to do 30 to 40 sessions. 30 sessions, if you see the Harris hip score, it's 90, from 38 it has moved on to 95. Oxford hip score is 59 to 60. Almost they recover the pain relief by about 30th session, and it goes on to maintain that even after 1 year. 1 or 2 years. And if you see the MRI reports in these two patients, it's the same as what it was before. It has not increased, and they're back to normal activity. So the next most important thing is arthritis, like rheumatoid arthritis. How my journey in rheumatoid arthritis it started is I had a patient, one old 72-year-old lady who went to MEDINEXT, went to all other hospitals, still came in a wheelchair. So then I thought, since being an anti-inflammatory, why not try it? So I put her in oxygen therapy. Immediately, 4th day, she walked back home. Till today, for 5 years, she's on regular follow-up, but with lesser amount of DMRDs. So the amount of DMRDs you need to give following this, but not for all arthritis. A person with rheumatoid or seronegative arthritis with severe inflammatory process, the disease is very active. So the activity of the disease can be controlled. So for this, you don't need 30, 40 sessions. All you need is about 10 sessions. So that the anti-inflammatory process where you give steroids. So after my oxygen therapy, the need for steroids in rheumatoid arthritis patient has come down totally. You don't need to give any kind of steroid in this, because what steroid does, oxygen does. Steroid work, oxygen does. And then obviously it has no side effects, and patients are not dependent on that. It's expensive, so they're not dependent on that. So this is one. How do you on it? Yeah, okay. So this is a patient with arthritis. This is how he came with limping. Severe pain. You'll know systematically. So when I say for arthritis, for all connective tissue disorders, basically it happens for all connective tissue disorders. This is on the 10th day. So basically how it works is it decreases the body inflammation, generally like how it works in fibromyalgia or anything like that. So the need for the need for further heavy drugs, a lot of drugs for arthritis is reduced. So this is another patient with bilateral sacroiliitis, suspected ankylosing spondylitis. He came severe bedridden. How is that? He came with severe pain. He was not able to, difficulty in walking. And this is his final. He came for review. For him, almost about 20 sessions had to give him for arthritis patients. So the sacroiliitis, he is still on DMRD drugs for ankylosing and this one, but his symptoms solved. The risk of other complications reduced. That's his testimonial. So it's a viable option, non-invasive, more numbers are needed. So other indications I've used is, as Sir said, in pyelonephritis, where deep-seated infections following stenting and following other things. I've used about 3-4 patients for urologists are referred for pyelonephritis. So anywhere where there is deep-seated infection, where your medicines don't reach or it's refractory to IV antibiotics, this will be an alternative, supportive solution. The most important is I have not actually had cases, and I had one case of spinal infection, a bacterial discitis. I did a biopsy and came out as bovine growth of organism. 5th day when I gave for we know discitis patients have pain. You need to load them with antibiotics, and then it takes about a month for the pain to settle down. 5th day the patient was all right. So any kind of deep spinal infection, definitely where the drugs takes a long time to reach, this will reach much faster, decrease the inflammation, the basic principle is it decreases the inflammation and decreases the edema. So I had one case of that. The next future where I see is periprosthetic infections. So when you are planning for a revision, I've had one patient now, you remove the implant, not only in periprosthetic infections, any tibial infection where an infected implant is there, you just remove the implant, followed up with about 10 to 20 sessions, the wound heals completely. It will not go in for a refractory osteomyelitis, most of them. So periprosthetic infection, nobody has used it so far. I have not had much case to use it so far. So, but I'm sure when you remove the implant and then wait for the period when you want to do the revision, this will control the infection to a great level, and then it will use. So there are a lot of areas in orthopedics where it's still unexplored, like periprosthetic. My opinion, periprosthetic infection when you're doing a revision or an implant removal after an implant. Of course, infection in post-traumatic patients after implant has come down drastically nowadays with the antibiotics, technology, everything. But still, when you have a tibial implant, I had a few cases of tibial implant removed and gave oxygen therapy. They completely settled down. I've not actually put it on that, but these are the other indications in orthopedics. There's a lot more indication in orthopedics coming up. Thank you.